Thank you very much for the very kind invitation to speak at this seminar today. Can I just ask, can everybody hear me clearly?
We can, thank
Is that
you.
okay? Because the sound was a bit difficult in the beginning. So thank you very much indeed. And I'm very delighted to be here. I'm sorry that I'm not there in person because for family reasons, but also can I just say that we've had our Christmas bugs a bit later in our family this Christmas. So I'm just recovering a bit from a bit of a chest infection. So please forgive me if I'm a bit, my voice sounds a bit strange at times. But Teresa's very kindly agreed to help me with the slides, and I will state why. I live in a rural area, and some of what I'm talking about today is very true for me. And one of the issues is the fact that internet connection where I live is very poor. And I have spoken at meetings before where I have just been completely cut off. So I just didn't want to risk that happening today. So Teresa's going to very kindly forward the slides. Can I have the first slide, please? Which I hope will make things a bit easier. So I'm presenting today some work that we have completed. Myself and the team, and I'll speak a bit more about that later, were successful in obtaining one of the NIHR funded partnership grants that the call came out in 2021. And it was to set up new palliative care collaborations to look at areas that perhaps hadn't been researched much previously, and to also include areas across the UK where little research had been carried out. Next slide, please. So I'll just give you some background to this work and why we were very interested to look at older people living in rural and remote areas across the UK. As I'm sure many of you will already know, that in the UK, we have more older people living in rural and remote areas than in some other countries. Wales, where I'm today, has the oldest population, followed by Scotland, England and Northern Ireland. The rather concerning fact is that by 2039, the number of people over the age of 65 living in rural areas in the UK will grow by 50%. That is concerning because the rural areas have an issue, that the fact that they have less younger people and people of working age living within them. So the issues that people face as they are rapidly aging, living in communities where there are less facilities, well, sometimes no facilities or no services, but also less people of working age who can actually perhaps support and help. As we all know, in the UK, we have a very, very serious issue with social care. The fact that we do not pay our social carers or respect them or value them in any way is a big aspect of that. But also the fact that social care is predominantly managed from urban areas. Carers prefer to work in urban conurbations, and many of them are not funded to travel. So there is a big issue in providing any care in rural areas as well. Next slide, please. The first statement, oh, sorry, it doesn't matter, but I'll in the first statement on the previous slide was that we know that the population is aging and the need for palliative care for people over the age of 85 is increasing significantly. Many of these people are living with multiple conditions. So we're not just talking about people requiring palliative care for cancer, we're talking about people requiring palliative care for respiratory disease and dementia and cancer and probably other conditions. And of course, frailty is increasingly being recognised as a condition that requires palliative care by itself. So our collaborative, it was designed to look at how we can, as a multidisciplinary team, explore the issues of how older people in rural and remote areas are cared for currently, and how we can support them and support the increasing numbers who are going to require care in the future. So it was a 12-month project. It was developed to develop research capacity clearly. So it was a very, very research focused clearly, and to co-develop research questions and also to develop proposals for further funding. I've listed here that the names of the core research team. Myself was co-lead with Nathan Davis, who is at QML-UL, and I'm sure you will recognise many of the other people, the names on here. We had excellent PPIE Betty George, who is a broadcaster and actually produced a very powerful documentary about 5 years ago, which was televised on by the BBC, of caring for her husband with dementia. And she, from that, has done a lot of work, particularly with the Welsh Government, in improving care for people with dementia, but also support for carers as well. And she was very, very helpful and well, she was integral to our work. Next slide, please. We had a lot of collaborators, again, people that and organisations that I'm sure you've all heard of. But we very much, when we were setting out to put the bid in for the partnership, we wanted a partnership that was real. I think sometimes you can set up things for grants that you think, well, this is good for the research, but we wanted to do things that was going to be real, that was going to be effective, and that we were actually involving the people who probably had the answers to the questions, or probably had the questions that needed answering, but also could help us find the answers to the questions as well. We had hospices involved, we had agencies clearly looking at older care, and people representing different organisations. Next slide, please. Alan Kelleher, who was a named collaborator, I'm sure is well known to you all. And Alan has founded the concept of compassionate communities and the public health approach. And again, when we were developing our application, we very much felt that probably looking at things from a public health approach lens would actually be helpful, especially in an area that rural and remote areas are generally under-resourced compared to urban areas, and that might be something useful to look at and to see how things could be improved for the future. Next slide, please. So what were our objectives? Well, our objectives were to establish a partnership, to develop multidisciplinary research. We wanted to understand what were existing models of palliative care for older people in communities, not just in the UK, but globally, to identify the priorities for research, and to build a future capacity for research in this area, because obviously this was a 12-month project. It was a very small project. When I was actually doing these slides, I realized that we actually did, the NIHR I think did quite well out of us. I think we actually did quite a lot of work in 12 months for the budget we had. But we very much, and this is still our objectives, that we want to build capacity for research in this area. Next slide, please. And I've just put a few photos in here, and these are photos of people who have had attended a rural daycare service. I think it just sort of shows, again, this lady celebrating her 95th birthday. And as we know, being 70 now is 70 is the new 50, and for some people 90 is the new 70 as well. And this lady actually lived to be 99 years old, and lived on her own with support from her family. So, but again, she was living with quite complex needs towards the end of her life, and in some ways was not actually cared for probably in the way that she could have been cared for, because she was in a rural area and the resources weren't there. Next slide, please. Obviously, if you're doing any sort of research, you need to find out what is known already before you start sort of thinking what you can do. There is very little, if any, research in the UK on health and social care with a focus on rural and remote. Most of our work all our work, I'm sure, is based in the urban settings. Sometimes there were papers that had a little mention about that they'd had somebody from a rural area who'd especially qualitative studies, but generally speaking, the work is urban focused. There is little known about the who, how, when, where of health and social care in the last year of life in this population as well. And one question that a few of us were very keen to try and unpack, and we haven't, and I'd be interested to have comments from the audience today as well about this, is where actually do older people in rural areas die? And I know that Irene Higginson was involved with a work that was published before COVID, which included people in rural areas. And the fact that you have 22% of people die in other places, and other places in ONS is a very broad term and includes settings such as a university hall of residence or dying on the street, for example, but it also includes the home of another person. So it is possible that quite a number of people, older people, are actually moving in to live with relatives for care in rural areas as well. Next slide, please. We carried out a scoping review to identify the evidence that was available for people in rural and remote areas and to look at models of care. We only identified 5 papers, 2 from Canada, 1 from the USA and 2 from Scandinavia. They were interesting models of care. Nurse-led models were very much looking at community, what we would probably call community nursing service, nurses from an urban setting going out, providing care, sometimes overnight care for people towards the end of their life. Volunteer-led was mainly like a sitting service that volunteers would go and sit with somebody who was approaching the end of life, an older person. And there was one paper that actually stated that they had tried to do, it wasn't a trial, but from their work, that they felt that volunteers, if they were supported, were able to actually look after somebody and care for them and provide valuable respite up until the last days of life, and that it could prevent hospital admission. Lots of talk about technology-based interventions, which I'll talk about a bit further. And the outcomes were patient well-being and place of death, which you'd expect. And if you want to read more about the scoping review, it's in the research the publication we did for the NIHR. Next slide, please. And this is sort of I think it just shows how rural settings are, that people in a very rural location and being some of the qualitative work that we've done actually so that people very much value the place and the area when they are living in a rural area. I think that is very, very true. Next slide, please. The NIHR were very keen that we focused on areas that were hitherto under research, so areas across the UK where perhaps not many studies had been carried out in palliative care. So I'll just go through the areas that we recruited participants from for our qualitative work and stakeholders as well. So in England, we had the area called Vale Royal, which is Cheshire West, which has quite a large rural population, and the Isle of Wight, which again, Isle of Wight has a very large number of elderly people and hitherto not had much research carried out. The southern and western areas of Northern Ireland. Northern Ireland has the largest number of people living in rural areas. That's not just old people, that's across the age group. And so we felt it was very important to include those two areas. Next slide, please. Scotland clearly has not only rural areas, but very remote areas. And we were very keen to actually include island communities if we could as well. So we included Ayrshire and Arran and the Highland. And we had a lot of participants from Scotland, which was great. Wales has the highest number of older people living within rural areas of the UK. We identified 2 areas. One was Conwy, Denbighshire, and also Powys. And Powys is a very interesting, Powys is a county in mid Wales, very rural county, does not have a district general hospital. So anybody in Powys who has any acute medical episode, it does have 2 or 3, I think, community hospitals, but anybody who is acutely ill would go to Shrewsbury probably, or sometimes to Stoke. So it doesn't have, so it's quite an unusual feature really, but it does have its own Powys teaching board. So they do a lot of work with education and palliative care is very important to them. Next slide, please. We did a lot of work with stakeholders because clearly we wanted to know what are the current issues and how did stakeholders feel they could be improved. As several of us had already done quite a bit of work in this area previously, we did have a lot of contacts already. We approached, as you said, you can see 53 organisations, 30 participated. It was interesting though that many people who work in rural areas have worked in rural areas for a long time and across many different organisations. So that you could have one person, but they actually had knowledge of quite a vast number of services, not only in their own area, but in other areas as well. So that was very, very helpful to us. We collected data by performer, and we also had 3 online workshops. A lot of this research was carried out in 2022, so we were just sort of emerging from COVID really, and we did a few follow-up interviews as well. Next slide, please. we asked one of the aspects that we were very interested in was models and interventions, and what stakeholders felt had been useful models that they'd been involved in. And bear in mind, these stakeholders were from health, social care, local authority, third sector, grassroots voluntary groups. So we had anybody who was involved in supporting older people in rural remote areas towards the end of life were eligible to be included. I think the models intervention were very interesting, really. They were from providing food and medication and delivery to very specific what we would term as a health intervention. So many talked about services, for example, hospice outreach service. So there was a rapid response team. Some were talking about a roving car that went out at night to rural areas. Social care was talked about as a service that was underfunded and not widely available, even for people approaching their very end of life. Also, some had planned overnight services in terms of respite. So people who were approaching the end of life, probably the Marie Curie night sitting service, but some areas had got their own night sitting service as well, which was very much valued clearly by families and those caring. Volunteer support, befriending services, practical help, people who would collect prescriptions, help with shopping. Some would help with practical tasks at home, or just sit with the person while the relative or family carer went out. A lot of talk about the fact that rural communities are often compassionate communities in their own right, probably without recognising that people, because they are living rurally and remotely, have to support each other, because they may need the support themselves, and they know that they have to support each other, and that for many people that is sort of a given. So it was something that somebody said, well, we don't really need to develop a model because that model is in being already, but clearly not in all areas. Several talked about training programs, end of life and palliative care training programs. Hospices had 24-hour helplines and palliative care services. Acute palliative care services had them as well. Some rural areas had set up social groups for patients and carers. Some had set up daycare services for older people generally, but were very supportive of people who were needing palliative care and approaching the end of life as well. Some had rural-based care hubs where there was a building where perhaps the doctor would do a surgery once a week, the nurse would be there, there would be some social support, there might be a food bank. So these care hubs within the community, and as I said, the community help schemes generally run by volunteers to support with the practical tasks. Next slide, please. The issues identified. Travel and transport. I'll talk quite a bit about transport later, because that came across very strongly from our qualitative interviews with carers and from stakeholders as well. The fact that rural transport is non-existent, or if it does exist, is not appropriate, and services that run, once a week when it's a Monday or something is not really helpful to anyone, and getting to appointments, carers finding it very difficult to travel, etc. The lack of broadband and internet, which is something I've just alluded to now, is a real issue. It really is. And I think, people in urban settings tend to be very dismissive of the fact that, well, everybody has access to the internet today. They don't. So not only have you got the issues of older people perhaps not knowing how to access the internet, but even if you can access it, whether it works or not is by luck or chance, really. There was also talk of palliative care not being commissioned in rural areas, in remote areas. And I think, I think that may mean the fact that very remote areas, not so much that perhaps it's not commissioned, is the fact that they can't access it. If you're in a very remote area, having a CNS that covers only that area would not be appropriate, for example, or having somebody that was particularly dedicated to that area. So I think that's what people meant, that they didn't have a dedicated person that people could be referred to. Recruitment and retention of staff was a major issue, and clearly it is across the board. This is not a rural issue, but particularly so that attracting people to work in a rural area is difficult because it is rural, but property prices are very high, travel is high, getting, local schools often closed, so you might need to travel 20 miles to get your child to primary school. So lots of issues why health and social care and workforce generally are not attracted to working in these communities. Very little or no respite for family carers. And again, that very much depended if there was a sitting service that was available. And I've got a bit more about respite a little bit later, but that was a big issue. That from stakeholders, they felt that there should be far more support for family carers, and that respite was vital. The challenges of administrating subcutaneous end-of-life medication. This is something that not many of our carers that we spoke to mentioned, but something that the stakeholders mentioned. I know there's been Catherine Evans has done some work on this, and also in Bangor there was the Cariad study in Bangor, which was looking at training family members to deliver subcutaneous medication, which clearly means that they don't have to wait 3 hours for the district nurse to be able to visit. So it is something that is being rolled out in some areas more than others, but several stakeholders felt that this was something that was a priority. It was interesting also that I think we all probably would recognise that we tend to work in silos. We perhaps say we don't, but we do tend to be very sort of based on, well, we do this and we don't really do a lot with them. And I think health and social care services don't work together, as we all know, as much as they could. But there was also this perception that there's a lot of provision, particularly in the more remoter communities, provided by the voluntary sector. And that the voluntary sector were there saying, look, we're here, we can do this, we can do that, but that often their services were not taken up, or that they didn't acknowledge that the depth of provision provided could actually make a significant difference. So very much a plea for people to work together. Next slide, please. So, and again, just further issues identified, that carer health, that's what stakeholders were saying, that because of the remoteness, accessing anything was difficult. So if you haven't got any respite, how do you leave your relative to go, for example, for a COVID booster or health screening? And the social isolation, if you're living in a rural area, perhaps not got good access to internet, haven't got a respite service, you don't see many people, you don't have carers coming in 3 or 4 times a day, so it leads to an isolation and an effect on the carer's health. The issue of urban migration. Not many young people can afford to live in rural areas today because property prices are so high. So the younger people go off to college or to train or to have apprenticeships. They don't return. So therefore, is no one left to care for older people. There was also some stakeholders talking about people who retire to rural areas. Obviously, rural areas are seen as very pleasant areas, which indeed they are, but that people perhaps retiring as a couple, both in good health. Perhaps one of the partners dies and you've got a person living on their own, and perhaps because of their health or because perhaps they've moved in later in life, there aren't the same opportunities to make social networks. So these people are more isolated, and that they perhaps struggle more than people who've lived in communities all their lives. Next slide, please. Sorry, excuse me. Trying to bring all this together and identify priorities. The priorities seem to be the skill mix and the retention and recruitment of the rural and remote workforce, and what services would be required with this rapidly aging population and this multi-morbidity. Trying to facilitate preferred place of death, which very often was home, and how that could be supported. And the role of technology, that was very much felt to be important, which of course it is. But also this preparedness for a future of people living with multimorbidities and frailty. How do they, I suppose some stakeholders were concerned, how on earth were they going to support this rapidly increasing number of people who would need support when they were already stretched as it is now. Next slide, please. We conducted qualitative interviews with family carers, and I'll just say that we recruited 21 carers. Bear in mind we were doing a 12-month study, so so this was done sort of started halfway through. We recruited carers. Some of us, as I say, had worked in these areas before, so we already had links with organisations. So we advertised via organisations. We also advertised on social media as well to recruit. We recruited, as I say, 21 carers. Majority were female, which I suppose is no surprise. A very good age range. Most were adult children looking after parents, some partners and one niece. Most were white British. We tried to recruit people who were not white British, but we were not successful. And the majority were interviewed remotely, as I say, because we were of the time that we were in. Next slide, please. In analysis, there were four main themes. One was retaining connection to place and heritage. And these were the themes that were important for the family carers and for the older person. If some of the family carers were bereaved, some were still ongoing carers. Support from the wider community and volunteer. Poor accessibility service due to transport and online support. Next slide, please. Retaining connection to place and heritage was very, very dominant amongst all the interviews, really. That older people, especially those who'd been brought up in rural communities and had lived there a long time, perhaps brought their family up there, really, really wanted to have that connection and to stay at home. And I suppose you could say that is true in urban areas as well. But there seemed to be a very, almost like the home was part of their heritage. And there was one example of somebody she said, I want to die here because my parents died here and my grandparents died here as well. So a very long history of one place, of a cottage that had been handed down across the generations. A lot of family carers were saying how important it was. We were talking about what was important to them in terms of health and social care at the end of life. So traditions and culture, obviously part of identity. Language was highlighted. In Wales, a significant number of the population do speak Welsh as a first language. I did not speak a word of English till I was 5, until I was sent to school. My parents were very cruel. They sent me as a pure Welsh speaker to an English school, but I survived. But for many people in rural areas, especially older people, they can barely string a sentence in English when they're well. So if you can imagine, if they have dementia or they've had a stroke or they've got any sort of illness, cancer, whatever sort of illness they have, the language is a big problem. And a lot of families were saying it was so difficult going to any sort of healthcare setting. One of them was talking about going to a memory assessment clinic where none of the staff spoke Welsh. So this poor man was already traumatized about going there. He could hardly express himself, and yet all the questions were in English. So how accurate was the assessment? And it is true that there's fewer people from rural areas are diagnosed with dementia. That were fewer people than there should be. So it's quite a low percentage. I'm sorry, I can't remember exactly what it is. But I think if you were a relative and you knew there's something wrong with your father or mother, going to a centre where you felt that nobody would be able to understand them, you can understand why you'd think, well, why do I bother? And I think we'd all be the same. But that was important. Some of the people from the Scottish Islands spoke Scottish Gaelic. And they actually said the same, that was a big issue for them as well. Although the Gaelic isn't perhaps as dominant a language as Wales, our own language is important to us, and we would respect all different languages that people speak within our communities. But it was a big issue. A lot of talk about the fact that if you're ill, the special foods that people would eat, bread with bovril and water or something, and that if they went to hospital and they'd ask for it, people say, what on earth do you mean? But this sort of the rural, remote traditions, particularly perhaps in more isolated areas, and the fact that their life was about nature, that in March the lambs would be born, in May they would be ploughing the fields, and in September they would be harvesting. So very much about the culture of rural life, even if they didn't live on a farm, but the fact that the seasons dominated their lives, really. Next slide, please. Accessibility. This was an issue, a big issue. Distance was a barrier to receiving all care, including palliative care. I think if I remember rightly, one person had been referred to a hospice. Many carers didn't see the point to be referred to a hospice because the hospice would be so far away that it would almost be another burden to try and get there. So there was little access to all services. The transport was a big issue. Some hospices had, some communities had local car schemes where there were volunteers who would have a community car who could take people to appointments, even GP appointments. You know, as we know, the day of home visits from primary care is no longer. So they had to actually get to an appointment if they needed to be seen. Somebody described I think it was a 200-mile round trip to go to the hospital for treatment. This is in Scotland, which is just staggering, isn't it? They lived on an island. So, you know, these journeys meant that people often didn't continue with treatment because it was too much. They just couldn't cope with it. And you can imagine if you've gone for chemotherapy and having a 100-mile journey home when you're feeling awful would be terrible. Some of them had access hospital transport, not people on islands, but people on the mainland. Said again, you know, having to be picked up because they lived so far away. They were the first pickup at something like 7 a.m, but their appointment wasn't until 11:30 in the day, and then they wouldn't get back till about 7 at night. So if you're unwell, you can just see again why people would say, well, I'm not going to have treatment. And again, that would carry on for palliative care. Accessing care was so weather dependent. So in the winter, people really worried if they had an appointment because the roads would be closed and they might have to wait for somebody to come and try and open the road for them. So big issues that we probably, I class myself as more urban than rural, I suppose, wouldn't think about, but big issues that were affecting people. And the fact that they said they didn't feel that the hospitals understood why they didn't want an appointment in the middle of January, for example, because they thought they were worried that they wouldn't be able to get there. So lots of issues about access in terms of that, but also the fact that the access was to a service that was very remote. There was very little access local to them because of where they lived. Next slide, please. Support from wider community, and I think this comes back to public health and compassionate communities. A lot of support from local communities, and you know, people like the neighbours, postman, the milkman, postman taking a prescription and going to collect it and delivering it at the end of his day when he'd long finished his work, the milkman collecting the shopping. You know, people became an informal part of the care team, really. That community support was often reciprocated. So somebody saying that somebody'd help them, so they told them that they could chop the tree down and have the logs, because obviously solid fuel and oil central heating, in the gas central heating is not available in rural communities. So lots of positive comments from being in a rural community. Lots of daycare services, older people's daycare services in rural communities, very much extended and were very supportive of people who were approaching the end of life. So people who had who were very well at home, but very much, you know, supported the families and said, look, we will look after them as long as we can. If you can get them to us, and families greatly appreciated having this respite, because it was so rare to have any respite at all. And again, this, you know, that the support for people perhaps who were retired to rural areas, and sometimes that perhaps that people don't think about, because of the lack of social network and the lack of any sort of statutory support was sometimes quite difficult, and a lot of people felt, and we'd had people interviewed who had retired, felt that perhaps if they'd have known that earlier, they perhaps would have moved back to be near a family earlier in their illness, as it were. Next slide, please. Online support. Again, this is very important that we understand that about a third of people in rural communities over 65 do not access online services, probably because they can't, or perhaps because the facilities aren't there, or that perhaps they can't afford. Lots of older people in rural communities don't have a mobile phone because the signal is so poor that they couldn't use it anyway. They'd have to drive 20 minutes down the road even if they had a car to actually so it is a completely different culture. So, you know, hospitals saying, oh, we'll text the appointment is not very helpful. Online appointments were difficult due to hearing loss, access, and I think we forget as practitioners, we all think that online appointments are wonderful, but also lots of issues about miscommunication and people not understanding what they'd sort of thought they'd been told or whatever. However, many family carers gained a lot of support from online support groups. They picked up a lot of advice. They felt they could speak to people they could understand, that would understand. It was all anonymous, so they felt very safe. Whereas, you know, in a rural area, everybody knows you, so sometimes saying something can be quite difficult if you're not sure, you know, if people are going to pass it on to somebody else, for example. So they were very grateful of that sort of support. Next slide, please. So the summary of the findings was really that we obviously this was just a partnership development grant, but that we wanted to do further work to understand how perhaps public health approaches to palliative care and also workforce as well can support communities, and very much the other aspect that actually the actual practical aspect of caring and administering end-of-life drugs didn't come up. We felt it would come up a lot more within our interviews than it did. It was more the findings that I've talked about now, but clearly some family carers said that they were very uncertain, say how to, somebody was in bed, how could they, turn them safely? How could they move them? Somebody said they'd had some equipment delivered, but nobody told them how to use it, so they didn't use it. So there were definitely practical aspects. So I suppose what we are thinking about is if there's some sort of training or resources that can be sort of developed, co-developed, that would actually help people in rural communities, because the access is not going to change, and if anything is going to get worse, because we know that the numbers of people are greater, but also that resources are not there and are unlikely to be there either. So, and again, that we've written that paper up in Age and Aging. Next slide, please. I'm coming towards the end now because I know questions. I've put this comment here because I think this was really, really powerful, actually. I'll give you a few minutes to read it, but I think it just shows that local authorities, generally speaking, don't understand what the issues are. Okay, next slide, please. So in terms of trying to improve palliative care, I think we have to understand what the situation is, which I think this work has helped us understand. The lack of infrastructure, there's no shop, the support and groups that were there pre-COVID are not, because lots of those groups folded and cannot or have not been reconvened. The lack of people of working age who can help locally means that you are expecting social carers to travel miles to come in and help. And as I say, social care is a mess anyway, so it is even more difficult in these areas. And the costs, I think we're also doing some work with Marie Curie at the moment on another grant, looking at financial insecurity end of life. And it costs more to live in rural areas. It costs more to die in rural areas too. And I think perhaps we don't, that's something that perhaps is not recognised as well. And that a lot of people in rural areas, because there's no library, they may not know of what benefits they may be entitled to. They're unlikely to see a social worker or a social care practitioner. So they are more, how can I say, detached from knowing what might be available. And I suppose for those of us working within palliative care services in any form, it's our duty to try and make sure that people know what is available for them to try and help them as much as possible. Next slide, please. So living in a rural area can look like this, and indeed it did look like this a few weeks ago when we had our first snowfall. Well, where I live, because we have some sheep in our field just outside the window there. So next slide. But also this is what it's like as well. And I do want to focus a bit on transport, and perhaps you think that's a rather strange thing to do, but transport is crucial. The fact that the Public Service Vehicle Act of 2000, which covers all the nations, including the devolved nations, states that buses have to have disabled access if they are 22 seats or more. 22 seats is quite a big bus, so you're not going to have a double decker going around rural villages, are you? Because they won't be able to get around in the first place. People battle to have bus services in rural areas, but a bus service is if it's inaccessible, people who are older, we've got far more older people in these rural areas. You may have young families who also need some help to get the pushchair or the buggy or whatever onto the bus. Buses with 3 steps are hopeless. And local authorities are now sending around these little postman pat vans with 2 seats in the front and 2 seats in the back and 3 steps to go in, and are telling the drivers that they must not get out to help anybody because they're not insured to do so. and then are using that as an excuse to say, well, actually, nobody's using our service, so you don't need it. So the inequities of rural living are getting bigger, not smaller. And again, this was something that came out very, very powerfully. The transport was mentioned in every interview that we actually did, regardless of which nation people lived, and regardless whether they were on an island in Orkney or whether they were in a village, you know, not too far from a town. It was a big issue, and I think it's something that perhaps we as practitioners don't realise, if we are serving rural communities, how difficult it can be for people to actually get to us or get to anywhere. And when we see people say, well, you know, come and see the physiotherapist in 2 weeks' time, how did they do it? And that was an issue as well, that they were saying that, you know, people don't get appointments all the same day. So they see somebody one day, they see somebody else in 3 weeks and whatever. It's impossible. So that's why these people do not engage with services. That's why they don't go for screening. That's why they don't try and perhaps get to see somebody in palliative care if they need it, because they may not know about it, but also actually getting there is going to be probably impossible as well. Next slide, please. So our plans, and I'm summarising this quite quickly. So we brought together patients, carers, stakeholders, and hopefully did some research that has been helpful and worthwhile for us, and hopefully for others as well, and hopefully has highlighted some of these issues which hitherto perhaps were not known so much about. Our thoughts are to try for further funding, clearly, to co-design some interventions, again, around health and social care, but perhaps looking at the fact that social care was a vital that everybody talked about, but social care may not be that easy to deliver. There are micro providers, there are sort of people setting up in, perhaps looking after 1 or 2 people in their own village, but that does not really help the issue. So supporting, training, helping family carers to be equipped, to be more confident, to know what to do, might be one of the possible way forward. But also there are lots of generic services. I alluded to older daycare services within these rural areas, who probably, with some additional training and support, could provide this level of generalist palliative care. Obviously, people who may need the specialist palliative care will still somehow need to have that care delivered from a remote location. But for the generalist, for the elderly, for the frail, those who perhaps do have symptoms, but symptoms that can be managed relatively effectively by somebody who has got skills and knowledge, that may be the way to upskill people and support them as well. And the support needs to come from either an acute setting or perhaps from a hospice, but to have more joint working, and also to have health, social care and the voluntary sector working together. I think that is vital. That really does need to change. Next slide, please. And I'll finish again with somebody, this lady was 100, but the volunteer, who was also from her village, was 82. So I think it just shows as well that you're never too old to help. And again, this reciprocity, isn't it, of helping and supporting people. So thank you very much indeed. I realise I've gone over my allotted 40 minutes. I apologise for that. I hope that some of what I've said has been helpful. And as I say, if anybody is interested to know more, please contact. We'd be really delighted to have more people as part of our group and our partnership. Thank you very much indeed.
Yes. Thank you so much, Mary. That was so interesting and lovely to see those photos as well. Just look at the chat. Just there's nothing in there. Just have anyone got any questions? If not, I will take. Oh, Irene's got her hand. I'll let Irene go first.
Hi there, and I hope people can hear me all right. And Teresa, it is a bit crackly in the room, I'm afraid, when people are in the room speaking. I've run up to my office, so hopefully the sound is okay for people there. So first of all, Mary, fantastic presentation, thank you. And what an incredibly strong amount of work. And I suppose I wanted to bounce on your last point about the transport issues. And I'm just wondering about the sort of solutions for that. because it's not easy, and I can't see it easily changing. But I'm wondering if there's a bit like hospices do have roles for volunteers or things like that. I mean, I definitely think we need to have more awareness of these issues, but I'm also wondering if there's other aspects. And I've got a second cheeky question, if I may, which is there any difference, do you think, between, because there's quite a lot being talked about coastal communities, which can be remote or they can be actually in cities. So I'm also wondering if there's anything that has been done, if there's anything particular about remote coastal areas versus remote general, or if it's kind of very similar.
Thank you, Irene, and it's lovely to hear your voice as well. And I'm sorry I'm not with you today. In terms of transport, you are right. There were, as I think the stakeholders research showed, there are models in sort of very much rural community-based models of people saying, look, we've got to do something. We'll get, some people from the Rotary or from, a group or whatever. People get together and say, well, I'll be able to drive a car on a Monday, you on a Wednesday, and somebody else, and they do it together very informally. But a lot of people were saying that those models are very much dependent on those people, and if those people are unwell or move, it doesn't work. I think hospital transport and volunteer drivers are crucial. I know some rural doctor surgeries do have people that will actually drive people in for appointments. Well, at least they did have. I don't know if that's still in being now. But I know that Hospice UK, in their excellent report, mentioned transport. And I think we need to lobby, because it is not fair. And it's like financial insecurity, whatever how you term it. It is such an issue for people, and it is actually costing lives. It undoubtedly is costing lives. And why should older people be deprived of treatment? More, everybody has a right to have treatment if they need it. So it is a real big issue. And I think I've actually spoken to our local assembly member who said that he's going to look into it, and I will jolly well chase him up to see if he does. But I think it is a bit. So I think we need to raise it and be aware of it, and lobby for it, because urban areas do generally have, perhaps they're not brilliant, but at least they do have a bus, and they do have a bus that actually is there most days. In terms of coastal, Irene, you are right. And if Sam Quinn from Glasgow, who is involved with our financial study, was here, he would be telling you that coastal rural communities are different. And some of the work that we're just doing the final analysis of that work now, looking at financial insecurity. We just looked at rural and remote. So we were looking at the rural villages and the remote islands or parishes or hamlets or whatever you call them. But some of the people on islands clearly are coastal. But I think they are different, and they have great inequities as well.
Thank you, Irene. Thank you, Mari. Hopefully the sound's a bit better now. I'm just going to go to a comment in the chat, or a question in the chat. It's from Amelia, who's a PhD student here, and she asks, if it was possible to fix the broadband issue, how much would this help? For example, with video call consultations.
I think it would make a big difference, but I think you also have issues of these very elderly people who have possibly, not seeing a laptop, or not, don't have a mobile phone. So if you're elderly living on your own, how do you have an online appointment? Because unless there's somebody with you, you can't probably operate the equipment. I know my mum, who is nearly 90, if you said to her, right, you've got an online appointment tomorrow, mum, get on with it, she wouldn't have a clue. She wouldn't. And she's not that disabled, but because she's never used that before. So I think you have to yes, broadband issue is a big issue, and coverage. But the issue also is with remote communities is because of their often, very hilly. It's the signal issue, and with mobile phones is really, really difficult. For young people, I know it's for everybody. So I think there's more to it, but also the fact that people don't have the IT skills. So it's a mixed issue. But I think it's just this awareness. I think it is this issue that people assume that everybody should be able to do online banking, that everybody should be able to pay their bills online, and they can't.
Yeah, absolutely. I think there's a couple of hands up in the room. Julia, I think you were first, and then we'll come to Joe.
Hi, it's Julia Byrne here. Thank you for a lovely presentation. Just on the, I do think it's really important to extend broadband, and there were government initiatives and promises that they would deliver broadband all over the country, and particularly to remote areas. And I understand the issue about hills, and you know, sometimes it's difficult. In COVID, though, during the COVID pandemic, lots and lots of older people did manage to learn to use technology, and there's a new generation, the baby boomers, following soon behind. So while I'm not saying that every older adult can or wants to learn to use technology, COVID demonstrated that an amazing number of people can. So I think that we should pressurise government to increase access to broadband, particularly in rural areas. The transport issue is a major problem. Some other countries, so I've got an example from Poland, the previous government wanted to level up between rural and urban areas and had a huge initiative to put tiny little buses with access into rural areas, and that made a huge difference for people. I very much empathise with your findings. With my colleagues in the National End of Life Intelligence Network, we looked a lot at rural areas. Sometimes another issue, not your super rural areas, but when I was working in the Southwest, we were talking about Somerset, Devon and so on. Sometimes it also matters what the background rate of care homes are, whether people can die there or be supported there. So, for example, in Torbay, which is coastal and a lot of rural, there's the highest proportion of care homes per 100 people over 75. So later, as you extend your work, it will be important to take those things into account. And certainly I empathise with your points about rural. There are lots and lots of older people who live in rural coastal areas, but they are all very different. Some are big places like Blackpool, and it's not rural, but you know what I mean, and deprived. And then others are very isolated, or Southport is absolutely full of older people and care homes. So these communities are quite different, but you've raised really, really important points. Thank you very much.
Thank you. So just to go quickly, that there was some research, I'm trying to think who led it, but there was some research that showed that people in rural areas tend to be admitted later. It was research based in Wales, that they had a later admissions to care homes compared to urban counterparts. And I don't know, was that because of the distance, or was that because what we found, that they just literally want, you know, however hard it is, however tough it gets, I'm staying here. So I don't know whether that is, but no, you're right, that care homes clearly make a huge difference, and that is the thing, that care homes also provide a lot of palliative care that probably some of us don't think about as well.
Yeah, thank you. I'll pass over to Jo. I've got another question. Hi Mary, it's Jo Bailey, one of your old colleagues from Liverpool.
Yes, hello.
Lovely to hear your presentation today. My question is, I wonder for rural communities whether we need to be more creative with the workforce and embrace transdisciplinary working. And this might also facilitate the broadband issues. If you have members of staff who are trained to, because even it's not just older people who don't want to use digital, it's when you're very ill and you're disabled, even if you can use broadband or IT, you physically can't anymore because of your condition. If healthcare professionals are able to go and facilitate video calls, healthcare assistant roles extended, and then if another member of the team is there while they're there, organise a case conference with other members of the team, but particularly transdisciplinary roles. If a physio's going, they're also the OT, they're also assessing for the dietitian, and just really consider how we can be more creative with our roles rather than being stuck in the traditional patterns that we have been.
Jo, I think that's an absolutely brilliant comment, and it's so true. But can I ask, how often do those roles exist, or how often do they deliver?
Sorry. How do you mean?
Well, do those roles exist? Because can you have a physio who also acts as an OT, also acts as a dietitian?
Well, I think that would depend on, that would have to be organised, but it does happen. So when I worked at Woodlands,
when I worked at Woodlands, the physios used to assess for the whole therapy team, and if we went beyond our scope of practice, we would refer on. But it made us more efficient as a team, and it reduced the burden on the patients because they didn't have to have so many serial assessments. So it requires, I mean, there are models and there's literature around transdisciplinary work. It does require new competency trainings and frameworks and regulation and so on, but it is possible.
Absolutely, that's great.
Thank you, Jo. And Mary, there's a couple more questions in the chat. I'll just read them out for you. Gosh, there's a lot. So Edwina says, thank you so much. This is really good work showing inequality exists in palliative care access, even in developed countries. I'm from Ghana and can really relate to most of the issues you describe. It strengthens the evidence supporting the need for integrating generalised palliative care competencies into health professional training.
Absolutely, yeah, absolutely. And I think that is starting to happen. Certainly in Liverpool, that there's some brilliant sort of models to try and do that. But I think we need to also look at integrating across, and I think also working far more with the voluntary sector as
well. Oh, you've muted, Mary.
Right. Sorry, I didn't mute myself, but that's fine. No, I think, sorry, what I was going to say is I think that sort of training models are being developed, aren't they? Which is great. But I think we also need to embrace the fact that there are a lot of voluntary sector organisations who are doing a lot of brilliant work, who I think as health professionals and social care professionals, we are not always that keen to work, well, not work with, but we don't always understand what they do for a start. So therefore we don't use, sounds a wrong word, but we don't utilise their skills as much as we probably could. And I think in rural settings, I think that's even more important.
Yeah, definitely. I am going to wrap us up just in the interest of time, but there are a few more questions and comments in the chat if you'd like to read them, Mary. Thank you everyone for attending today. Our next seminar is going to take place on the 25th of February, and that is Professor Lynn Turner-Stokes presenting about tough decisions making for adults with acquired brain injury in a vegetative or minimally conscious state and practical aspects of palliation. And please take a moment to fill out the evaluation form that Jodie's posted in the chat. Thank you, everyone. Maybe a last round of applause for now.
Thank you very much. Thank you very much again, everyone. Thank you.